Hello everyone, I'm just going to share my presentation. So welcome to my talk entitled Ethical Aspects Around Mass Screening for Celiac Disease at the Screening Symposium in Denver. My name is Jonas F Ludvigsson. It would have been lovely to be with you in Denver. I hear it's perhaps the only city in the world situated exactly 1 mile above sea level. I've also heard about your airport, and I love sports. And I know you have some really great sports team, perhaps more great sports team than any other major city in the US. So I'm going to give you an overview of my talk. I will first give a short background on celiac disease. I will then talk about what is mass screening versus case finding. I'll talk about ethical frameworks and the benefits and harms of screening. But I'll also say a few words about myself, since that will flavor my talk. I'm from Sweden, which has one of the highest prevalences of celiac disease in the world. I'm an epidemiologist and I like numbers. I'm also a pediatrician and I work to a large extent in the wards, also with cancer, diabetes, severe infections, but also a lot in the emergency department. And I'm also the scientific chair of the SCRESCO study, one of the largest randomized colorectal cancer screening studies in the world. Finally, I was the lead author of this paper in the UEG journal in 2015, and it is the most cited paper about general aspects of celiac disease screening in the last 20 years. So what is celiac disease? Well, celiac disease is, as you know, an autoimmune enteropathy triggered by gluten, and it affects about 1% of the Western population. That is actually important because it's important for the so-called positive predictive value when we test for celiac disease. Symptoms may vary, also very important, since the disease may be hard to find, and that is actually a reason for screening. Treatment is lifelong and consists of a gluten-free diet, and we should not overestimate the burden of a gluten-free diet. So for screening, it is important to prevent something, and one thing we want to prevent is complications of celiac disease. And actually, a lot is known about complications from diagnosed or symptomatic celiac disease. Much less is known about complications from asymptomatic and undiagnosed celiac disease. The figure to the left here is from our paper in Nature Review in Gastroenterology and Hepatology in earlier this year. And importantly, the mechanism behind the association between celiac disease and syndromes is genetic, yes. But I believe that a large component of the increase in autoimmunity in celiac disease may also be genetic. The paper we published in Journal of Autoimmunity 2024 by Johan et al. Showed that the duration of celiac disease does not really seem to impact on the risk of autoimmunity in celiac disease. Also important is this figure from the same paper, Nature Review Gastro, where we show that persistent inflammation, that is, I would say, the absence of a high gluten-free diet adherence, has been linked to lymphoma, yes, to hip fracture, perhaps bone mineral density, poor such, and perhaps to mortality, what we're not so sure. But importantly, mucosal healing is not linked to the diseases represented here by blue dots. And mucosal healing does have some side effects. It seems to be associated with an increased risk of some other diseases. And this is something we have to consider when we recommend a gluten-free diet to a child discovered by screening who used to be asymptomatic. So what is mass screening? Well, mass screening is testing asymptomatic individuals at a population-wide approach. And there are some examples in Italy, but also some US pilot programs. I contrast this with case finding. Case finding is a targeted examination of individuals or groups who are suspected of having or at risk for a disease. The WHO has set up some criteria for when it's worthwhile with general population screening. And I think the first criteria are fulfilled. Not much to discuss. What we should focus on is this one. If undiagnosed and untreated, the disease will lead to severe complication. I would say we do not know. The last criteria, testing and treatment, is cost effective. I would say I'm not so sure. And we've reviewed these criteria and the answers to them, or our thoughts in the UEG journal publication in 2015. So there's a clear ethical distinction between screening and case finding. Screening is initiated by institutions, not individuals. There is a higher ethical threshold required for mass screening, and there is a risk of overdiagnosis and overtreatment in mass screening. In contrast, I see very few problems, ethical problems with case finding. So what are the potential benefits of screening? Well, we hope to detect celiac disease early, and we hope this early detection might prevent some complications. We also hope that we will be able to improve the quality of life in some patients detected early. But there are potential harms from screening as well. And this often has to do with the sensitivity and specificity of tests, which are not perfect. There will be false positives and false negatives. If we have a positive test in someone with celiac disease, that's great. If we have a positive test in someone without celiac disease, that is bad. That is a false positive. If we have a negative test in someone without celiac disease, that is great. If we have a negative test in someone with celiac disease, it's false negative. That is bad. And what are the complications of this? Well, false positive tests they will lead to anxiety, stigma, unnecessary biopsies, a burden of gluten-free disease, which is, you know, major. And there may be nutrition concerns in these children because we more or less force them or recommend them to go on a gluten-free diet, but they don't have celiac disease. In those who are false negative, there is a risk of delayed diagnosis. Only last week did I have a boy in my department, in my outpatient clinic, who had Down syndrome. He had undergone testing, case finding, at an earlier stage and turned out to be negative. Then he had symptoms. But the fact that he had this initial test, which was negative, delayed his diagnosis substantially because people were unwilling to retest. So screening must minimize misclassification. I think this is especially important since we deal with people, children, who at the outset are healthy. And then we have the costs and resource allocation, which I think could be included in the category potential harms from screening. Also important before we initialize mass screening is the adherence to a gluten-free diet. Because if we diagnose someone and they do not adhere, then what good have we done? Typically, the adherence in celiac disease is probably around 80%. It means that with a lower adherence, we have less benefit from screening. And I suspect that the gluten-free adherence might actually become lower in asymptomatic kids, in those screen detected. They have low motivation. The gluten-free diet is at the same time socially and economically burdensome. Last week, a journalist called me. She was going to talk about our paper in the BMJ, authored by Jack Doyle, Ben Level, me, and others. And the journalist said, I've talked to a number of people, and they all complain about how difficult it is with a gluten-free diet. The gluten-free diet is really burdensome, is it? And I agree, it is really burdensome. Besides, the gluten-free diet is not always perfect. There's a risk of nutritional deficiencies. There's a risk of B vitamin deficiency, low fiber content, and deficiencies of other nutrients in non-fortified food. So asking someone to start with a gluten-free diet is not a minor thing. There's also this issue of informed consent in pediatrics. I struggle with this every day since I work with kids. I mean, children cannot provide legal consent. Instead, the parents must decide on behalf of the child. Sometimes the child is against, but then the parents say, you have to, often backed by a physician with his or her authority who supports the parents and also say more or less, you have to. Okay. Becoming adolescent, it's more tricky. They have a capacity for assent. Maybe there will be ethical tensions between parental authority and the autonomy of adolescents. There's the issue of equity and access. Screening has to be fair. But at the same time, we know the screening uptake varies by socioeconomic status and by education. Do we believe that in a country like the US, we will have equal uptake of screening? Instead, I think there may be a risk of excluding disadvantaged groups. There is a risk that not everyone will afford the gluten-free diet, and that access to gluten-free food varies between different parts of the countries. But at the same time, I think it's ethically imperative that if we are to screen, screening must be equitably implemented. Can it? One way of refining screening is adding HLA typing, genetic screening. Okay, HLA DQ2, DQ8 testing can pre-select children at risk. It does improve efficiency, but we still have to test very, very many kids. And genetic testing has some special privacy concerns. It may also reveal risk for other autoimmune diseases. So what do we tell parents who say, so you mean my child has an increased risk of developing autoimmune disease? Should my child be regularly tested? Should I be worried because you now tell me he's HLA-DQ2, DQ8 positive? That is a concern. There's also the concern of data privacy and secondary use. Screening generates sensitive, massive health and genetic data. I think there is a risk of misuse by potentially insurers, by employers, and also the commercial access to these data might be controversial. How do we handle that? There's the issue of repeat screening. Celiac disease can develop later in life. This is a figure from my paper with my postdoc David Bergman in Gut 2022 when we looked at the incidence and prevalence of celiac disease. Here is the incidence of diagnosed celiac disease per age in women and men. I assume that most testing would take place in early childhood, here symbolized by 2x at different, with some kind of different interval. Because one-time screening will miss cases. So probably we will test twice. But repeated testing increases costs and burden. And there's no consensus on optimal frequency. So when do we run the test? At these ages or at these ages? There's a risk of potential overdiagnosis. Screening would probably detect quite a few cases with mild or potential celiac disease. It's uncertain to what extent these will progress to MARCH 2 and MARCH 3. So in consequence, there's a risk of unnecessary treatment. And how will people be affected by gluten-free diet if they do not really have celiac disease? Well, we have some clues from a paper published by Ben Glebwell in the BMJ, where they found that a diet which is low in gluten is associated with coronary heart disease. There's also the effect of psychologically labeling healthy children. You have celiac disease, you have a lifelong chronic disease, and you have to adhere to this treatment for the rest of your life. That is a hefty price to pay. There are the commercial interest. We have diagnostic companies, we have the gluten-free diet industry, and there is a potential for a conflict of interest here. I think we have, before we decide upon general screening, clearly discussed the transparency issues and the regulations. So what are the alternatives? Well, one alternative, which I think is very attractive, is case finding. Case finding targets high risk or symptomatic individuals. It is more cost effective. There are fewer ethical concerns, but we will miss cases. So to compare mass screening and case finding, I think the mass screening has a broad reach. Case finding is more targeted. The cost of mass screening is higher. Cost of case finding is lower. The benefits of mass screening, I would say at present, are lower. Case finding, higher benefits, certainty. And the ethical risks are higher in mass screening than in case finding. There are a number of stakeholders in celiac disease screening. We have children and families. We have healthcare providers. We have policymakers. We have commercial entities. But we also have the researchers. And I sometimes feel that some research may want celiac disease screening because it will prove that celiac disease is an important disease. I call this the Olympic sports bias. When a sport is not yet an Olympic sport, everyone performing that sport wants it to get into the Olympic Games, because when it enters the Olympic Games, it will be recognized as a more important sport. It will get more coverage, more sponsors, etc. And there could be something similar in celiac disease. I don't say that everyone is aware of that, but it could be unconsciously a strive towards having general mass screening as a way to qualify into those very important diseases. So screening is really about, given the available resources, do we do the right thing for the right reasons? So speaking about resources, I want to discuss the alternative cost of celiac disease screening, which is also an important ethical issue. There's an ethical need for cost effectiveness in screening, but at the same time, screening programs are costly. Programs include programs include testing, biopsies, follow-up, dietitian support, etc. And there's an opportunity test. What else could have been funded? There's some very important assumptions made before we calculate the cost effectiveness, because cost per quality adjusted life year varies widely between studies. And it all depends on things such as adherence to diet, quality of life gain, complication risk, and case finding is often, in my mind, more efficient. So, there are two studies in Sweden. Researchers screened 12-year-olds, and they estimated the cost per quality of $40,000, but they assumed a very, very high gluten-free diet adherence. And with a gluten-free diet adherence closer to 80%, the cost per quality would have been different. The young adult screening in Italy assumed a gluten-free diet adherence of 98%. I would say highly unlikely. And still, they had a cost per quality of around $50,000 per quality. Another study in the Netherlands presented much, much lower cost per quality, but at the same time, that study was restricted to individuals who already had at least one celiac disease-related symptom. They also presented very, very low costs. For instance, test cost, including staff time of 25 euros or $25 per test, which I think very few other countries would be able to achieve. So in my model, next slide, I've been using the Swedish data of around $40,000 per quality. So I've been trying to model the cost effectiveness in the US of a nationwide program for celiac disease screening. I have some assumptions. A 1% prevalence of celiac disease, that TTG about 10 times above the upper level of normal, would only be retested by TTG, otherwise with a biopsy, that we would have a gluten-free diet adherence, 80%, and that undiagnosed celiac disease would be associated with anemia, reduced well-being, fractures, etc. And then I've entered a number of costs per test and staff time, parental time into ChatGPT, Microsoft Copilot, and asked it to calculate the cost. Assuming that we have about 3.6 million births in the US each year, and we test them twice, and 80% opt to do the screening, and we assume we have in routine healthcare, not an expert, not a tertiary center, but in routine healthcare, a sensitivity of 93%, specificity of 98%, and testing 5.6 million kids per year. The number of true positives per year would be 53,000, and then we have 2% false positives as well. The total cost of this program would, according to Microsoft Copilot, probably be around $500 million. So what can we do with $500 million if we choose not to screen for celiac disease? We could run about 20 million fit tests to detect colorectal cancer. We could close gaps in routine immunization, millions of doses, setting up mobile vaccination clinics. Vaccines typically have a cost per quality of less than $5,000. We could vaccinate between 15 and 20 million kids against influenza, which would reduce hospitalization, mortality, complications. We could launch a screening program for lead poisoning to prevent irreversible neurodevelopmental harm. We could have a huge impact on cognitive health. Or we could launch a mental health screening program in the US, trying to detect ADHD, depression, anxiety, training thousands of school counselors, giving therapy for hundreds of thousands of kids with mental health problems. Or we could screen all kids in the US for celiac disease. These are my take-home messages. Celiac disease is common and it's treatable. Celiac disease is important. I did not write more than 300 papers on celiac disease because I consider it to be trivial. But mass screening raises ethical concerns, and I think the benefits for asymptomatic children are unclear. I think case finding at this stage remains preferable, and I think ongoing research is essential. I fear if we do celiac disease screening, I think it should be for the right reasons. I fear for Olympic sports bias. And I still think there are some research gaps which needs to be filled before we consider mass screening. I think we need to know much more about the natural history of asymptomatic celiac disease. We need to know more about the long-term outcomes of early diagnosis and the cost effectiveness in a real-world setting. We need to know more about the psychosocial impact of being assigned a diagnosis, both among those with a true diagnosis, among those with a false diagnosis. And with that, I'd like to thank you for listening to my talk. Please contact me if you have any questions. You have my details on my professional website at Karolinska Institute or on my LinkedIn page. Thank you very much. Have a nice day. Bye.